current treatment options for breast cancer?
Well, the treatment involves local control of the disease, which is usually with surgery and possibly radiation, and then systemic control of the disease with chemotherapy if necessary. So patients who are diagnosed early stage or possibly with in situ disease, a pre-invasive disease, then local control is what the focus is. And those options for local control of the disease very often are either a lumpectomy or what we call breast-conserving therapy and mastectomy. So beyond that, if patients with more advanced disease, then there may be indications for chemotherapy for systemic control. So as a reconstructive surgeon, our choices for the options for reconstruction have to depend on what treatment option for both local and systemic control are chosen. We do these days perform reconstruction for breast conserving therapy, and in fact we're trying to be more aggressive about recognizing patients who are candidates for that, and even performing immediate reconstruction for breast conserving therapy. We call that oncoplastic surgery, where we anticipate what the defect will be after a lumpectomy and try to reconstruct that immediately at the time of the cancer treatment to avoid having more disfigurement or distortion of the breast, the appearance of the breast.
Dr. Polo, one of the recent research showed that in patients who don't have the spread disease and that don't have the metastasis in lymph nodes, they can eliminate the radiation treatment. So what is your opinion about that?
I mean, that's
Dr. Polo, what do you think are the most important aspects of the emotional part of dealing with breast cancer?
Well, I think it's basically it involves body image in large part. That's what we're trying to address. That's what we're trying to restore for women for the most part. We're not trying to restore function of the breast. We're not trying to restore lactation. If we could restore nipple sensation, we would do that, but we're not able to do that just yet. So we're trying to restore the appearance of the breast and, a woman's self-esteem and self-confidence and body image so that they're comfortable, moving on with their lives.
Dr. Polo, how usually women cope emotionally with the breast cancer treatment and their rehabilitation period?
Mm-hmm. Well, it's, in my experience, it's a tremendous adjustment for every patient. I think where we've made great strides in treatment of breast cancer, one area is in the emotional support that is available to patients, especially early on in their diagnosis, and even years afterwards as they continue to live with the disease. But most large communities have support groups that offer very sophisticated education to patients. They offer emotional support from women from all walks of life who have been through the same process, possibly, and very similar to what each individual newly diagnosed woman is going through. So there are lots of resources in most communities. Some patients have those resources available among their own friends and family. But it definitely makes a big difference, I think, in dealing with the treatment, and can make a big difference in outcomes as far as your whole outlook on it, and support that you have. I think going through the process plays a large role.
Breast cancer is not a deadly diagnosis anymore, and even for women after their original treatment, the modern medicine, modern oncology and plastic surgery is able to bring multiple options how they can continue fighting with the disease and how they can regain their life. Dr. Polo, what do you think are the better perspectives in breast cancer surgeries, and what are the new modalities in treatment of breast cancer?
Well, from the reconstructive standpoint, the most recent advances basically, have occurred on all fronts of breast reconstruction. With the autologous tissue reconstruction, where we have moved is toward limiting the defects at the donor site when we're transferring tissues from one part of the body to the breast to reconstruct the breast. Basically, we're able to preserve more of the tissue at the donor site and avoid morbidity at the donor site and loss of function and possible complications, and still achieve the same reconstruction. With implant reconstruction, basically advances have provided us with better implants, safer implants, implants that can more accurately reconstruct and reproduce the appearance of the breast. And then also we're using tissue engineering products routinely these days for implant reconstruction. These are tissues that are taken from human or animal sources and are processed so that when they're transferred to a breast cancer patient, they're not rejected. They're accepted as part of the patient's own tissue. And this is where the future is. We talk about what we call the bioengineered breast, where eventually we hope that we're able to reconstruct the breast and regenerate a breast without increasing the risk of recurrence of the breast cancer. This is where we seem to be headed with the fat transfer techniques. We're routinely performing fat transfer to restore, smaller defects after reconstruction. This is in combination with an implant or an autologous reconstruction, and then when we still have some minor defects, we're reconstructing that with fat transfers. The hope is that eventually we're able to completely reconstruct the breast with fat transfer and possibly with involvement of some stem cell transfer. The concern with the stem cells in breast is if we're trying to reconstruct an organ that is susceptible to cancer and has already had cancer in that location, we don't want to reactivate that or stimulate that in any way. But eventually, as this science advances, we hope that we can completely reconstruct the breast with the patient's own cells and own tissues without having any type of prosthetic material present.
Thank you. Dr. Polo, why breast reconstruction became a more viable procedure to fight the deformities after the partial mastectomy and complete mastectomy?
Mm-hmm. Well, there's been a sort of new field that has developed in the past several years that we call oncoplastic surgery. And basically it just involves more close cooperation between the surgical oncologists and the plastic surgeons. And it has allowed us to sort of advance the indications for breast conserving therapy, where more women may be considered viable candidates for breast conserving therapy or lumpectomy or quadrantectomy. One of the contraindications to breast conserving therapy is the size of the tumor relative to the size of the breast. So in the past, if a patient had a relatively large tumor compared with the breast size, it was anticipated that there would be such a severe defect from the lumpectomy or quadrantectomy that it wasn't worth performing that procedure. Now, it's not just the surgery, it's the radiation that follows breast conserving therapy in most cases. The location of the tumor is also important. A tumor just beneath the nipple-areolar complex is going to involve removal of the nipple in the areola with the lumpectomy. And that may cause enough disfigurement of the breast that it's not worth preserving some of the breast if what's left is going to be so disfigured and distorted. And oncoplastic surgery basically involves immediately reconstructing a lumpectomy defect, so that if we perform reconstruction immediately, either with implants or more often with the patient's own tissue, we can have a very acceptable outcome and not have distortion or disfigurement that we would have otherwise if we were to wait and try to perform a delayed reconstruction. So sometimes this is not anticipated, and after an attempt at breast conserving therapy there is disfigurement and distortion. Very often we can correct that or significantly improve on it with a delayed reconstruction. But oncoplastic surgery basically involves anticipating those cases and preventing those cases by performing the reconstruction immediately, and even, again, extending the indications where a woman who in the past would not be considered an adequate candidate for these procedures, if the reconstruction is performed immediately, may be. And we never want to compromise the treatment of the cancer. So sometimes when we perform this oncoplastic surgery, it allows the surgical oncologist to take even more tissue, to have an even more wide margin, and therefore better treatment of the cancer, because we're performing the reconstruction at the same time, and they're aware that we're doing so. Whereas if the reconstruction was not performed, they may be more conservative to try to avoid severe disfigurement.
Thank you, Dr. Polo. Thank you very much for your time and wonderful answers to the questions.